to this webinar organized by Reuters Events. My name is Arundhati Parmar, and I'm the editor-in-chief of MedCity News and also the moderator of our discussion today. Before I introduce our expert panel, I wanted to provide some context for our discussion. Last year, the Chartist Group surveyed 143 health system executives, asking them about their 5-year plan for digital transformation. A full 39% said that they were going to launch a hospital at home program within those 5 years. Now, the same question was asked a year before, and only 18% reacted the same way. So you can see how hospital at home programs are really top of mind for health system executives. Of course, they cannot do it by themselves. They really need the help of tech vendors. And you will be hearing from one of them today, that is Bioformis. In our coverage at MedCity News, we have covered several different hospital at home programs. Bioformis is certainly one of the more prominent ones, but there are others as well, such as Medically Home, Cadence, and others. So with that context, let's dive straight in. I wanted to go straight to Tahir Haq, who is with Bioformis. Tahir, why don't you introduce yourself?
Good afternoon, everyone. My name is Tahir, and I am the Senior Medical Director of Hospital at Home at Bioformis. I am an internal medicine physician by training and practice at the Home Hospital program at Brigham and Women's in Boston. I hold a secondary appointment in the Division of Global Health Equity, serve as an instructor in medicine at Harvard Medical School, and am an associate faculty member at Ariadne Labs. My primary work focuses on improving clinical care through innovative delivery and health equity initiatives. It's a pleasure to be here, and I look forward to being part of the discussion today.
Welcome to you, Tahir. Next, let's go to Dr. Zenobia Brown with Northwell.
Hi, good afternoon. So happy to be here. I am, in fact, Dr. Zenobia Brown. I am the Associate Chief Medical Officer of Northwell Health, as well as the Executive Director of Health Solutions, which is our population health care management organization for Northwell Health that creates, implements, and designs innovative clinical programs that, similar to Tahir, bring equity into the value equation, as well as move and support Northwell in its transition of clinical care and optimization of our value-based programs.
Welcome to you, Dr. Brown. Sharon, can you introduce yourself as well?
Sure, I'm Sharon Anderson. I'm the Chief Virtual Health Officer at Christiana Care Health System, and I'm also the president of a wholly owned subsidiary, the Center for Virtual Health. The Center for Virtual Health is really our commitment. We believe that the future of healthcare is virtual. And I think the most transformative thing we think is happening is that the home is the new venue of care. So the Center for Virtual Health drives many programming, all virtual. We have virtual primary care, virtual concussion care, and we operate the hospital care at home program as well.
Thank you, Sharon. I'm going to stay with you. Can you talk a little bit about when you launched your hospital at home programs and then what kind of outcomes you are seeing?
Sure. We launched the program in December of 2021. We really got that program up within less than 6 months. We had a lot of urgency. Remember, it was still COVID, or one of the several surges of COVID. And we admitted our first patient right before the holidays, and we had a slow ramp up by design. And I highly recommend a slow ramp up because it is really a different way of delivering care. Today, we've admitted over 400 patients. We have 2 EDs that are directly attached to hospitals and a freestanding ED we admit from. And we also take patients that have been in the hospital a few days and transfer them back to their home to continue their acute care stay. And, you know, the program has just been amazing. The outcomes are so good. We've only had 1 infection in those 400 patients, and that actually was a patient who acquired that infection when they were in the hospital before they transferred to their home. Our 30-day readmission rate is under 10%, which for a Medicare population, which is our primary population, the national rate's over 17, sometimes higher. I think our net promoter score is the most amazing results we've seen. Patients love this model of care. We're running around 89% compared to an average brick and mortar, which is like 38. We've had 0 mortality. And so we have about a 10% escalation rate back to the hospital, which is probably where we want to sit. I don't think a zero escalation rate where patients have to go back to brick and mortar is a good number, because that means we're not taking the right level of care patients. But I also don't think more than that would be a good thing as well. So we've been just really impressed with the outcomes, and there's a lot of momentum in the organization to continue to grow this program.
Those are some impressive numbers. Tahir, if you can talk about your hospital at home programs, please.
Sure. So the Brigham and Women's program started pre-COVID about 7 years ago. We have published data on our outcomes, including improvement in patient outcomes, reduction in resource utilization, as well as cost and capacity building among other benefits of our program. Some highlights include a 38% reduction in cost of care and a 70% relative risk reduction in readmission compared to our traditional inpatients. We've also created significant capacity, 419 bed days over a 95-day period during the 2020 COVID surge. I think what's less talked about in terms of benefits of our hospital at home program is being able to deliver care in the home has a profound impact on the patient's perception of care, as well as patient and clinician satisfaction. I would say that the clinicians that practice in our program, the doctors and nurses, are amongst the most kind of satisfied across our health system. And I strongly believe that, our program drives change because of its high touch and personal nature.
Dr. Brown, if you can talk a little bit about what you've seen at Northwell.
Fantastic. And I think the themes will I will reiterate some of the themes of my counterparts here, which is, when Northwell came together to build our hospital at home program, it really was bringing the full force of Northwell's assets. So it sat on the chassis of our house calls program, which has been in place for many years, under the auspices of Independence at Home. So for a long while, kind of working through what are the different components that you need to provide very high intensity services, but as Tahir said, and also Sharon, that where there is the foundation of that experience is the relationship with the patient, right? It is entirely patient-centered because you're doing it where the patient is physically centered. So that meant bringing together our community paramedic group, our geriatrics team, our infusion care folks. So when we talk about how do you start to even think about what this looks like, it does start, as my counterpart said, with what are we trying to build here in terms of the patient experience? Where do we want these outcomes to be? And then how are we doing that in a way that integrates with all of the components of our healthcare system? And then I think, bringing in the right partners to make sure that that program has consistency and that the patient is that whatever we're doing at home is at least, if not better, than what we would be doing in a building.
So I wanted to pick up on what Sharon said and see if you agree with that, Dr. Brown. She mentioned that it's always good to ramp up slowly when you do hospital at home programs. Why is that?
Yeah, and I'm sure Sharon will have some thoughts on that as well. What I think one of the challenges, and we will I hope kind of get to this point where we're talking about why is it important to have even a hospital at home? But healthcare isn't built this way, right? Healthcare has been traditionally very transactional, and that's how all of it is designed. So the minute you take healthcare out of a transactional environment and then put it into, what I'll call free range outside of brick and mortar, there are 1,000,001 logistical puzzles that you have to solve because healthcare is not designed to do this. So if you do it for 100 people all at once, you're kind of inviting disaster. So to Sharon's point, this concept of, you've got to figure everything out from, why or why not your Wi-Fi, jetpack is not working at that address when clearly Verizon says it should. And, not to use any sort of particular names, but, and we have very good success with Verizon. It's amazing, of course, but I think it's all of those kinds of things, right? It is traffic on, the LIE, and how is a medication going to get where it needs to go when there's bumper to bumper. So again, starting slowly, making sure you have solutions for every single one of those logistical challenges is key.
Sharon, if you can add to that.
Sure. And every health system has different assets. So we started with really outsourcing a lot of our services that were required in the home. And you don't just have one set of services. For every service you have to have redundancy. So you have to have two. So if you're going to outsource some of the nursing care, you have to have two agencies. If you're outsourcing oxygen, you have to have two agencies that are going to deliver that. And so it really is an orchestration of all those vendors and the services that you're directly providing. And it's acute care. So it's not like, you can wait a few days, or that medication can be that late, or the oxygen can never be late. So I think that that's why it's important. There's, as Dr. Brown said, it's a lot of, orchestration of things that have to happen when they do. And so I think you want to be careful as you build that programming, and you're learning constantly about what's working, what's not working. And so I just think it's the safer thing to do. It's really about, you want to deliver a high quality, safe experience for patients. And I think actually the home can be higher quality and safer than a hospital, but you have to make sure all those pieces come together perfectly.
Tahir, slow and steady wins the race.
Yes.
Absolutely. We started off our program with an average daily census of 4. And the reason being was it took time for us to realize how long it takes for a clinician to go to the home, kind of to spend time with the patient, deliver the intervention before they can go to the next patient. And I think getting up to that comfort level before you scale is key, as Sharon and Zenobia mentioned.
Hospitals are under tremendous financial strain as a result of COVID. And I'm wondering if there's a way that each of you can address, and we'll start with Tahir. How much do these programs cost? I'm sure there's a range and there's not a fixed answer, but what should hospitals that are, or health systems that are thinking of launching a hospital at home program know in terms of cost, upfront cost, let's say?
I'll defer to my colleagues for maybe more specifics on cost, but what I would highlight is it's important to understand what resources you will insource versus what you will outsource. And I think that contributes a lot to the cost discussion. Major things to consider are, clinical care. So where are you getting your physicians and nurses from? The second big bucket I would say is diagnostics. So phlebotomy, radiology, as well as interventions. So medication sourcing, infusions, as well as home health aides, social work. So putting all of that together, anything that a patient might have required if they were in a brick and mortar facility, and going line by line and pricing that out and seeing if it's something that you have available within your health system resources, or if it's something you have to kind of outsource, like I mentioned.
Dr. Brown, you smiled, so I'm going to you next.
Yes. I'm Tahir, that was incredibly eloquent. And I think you broke it down in terms of, understanding what you need to buy, build, or bolt on. And in those major categories, right? It is FTEs, and then it is sort of these other fixed costs of just what do you need to take care of someone. I think the other investment that has to get assessed is just the technology investment, right? But why I smile whenever there is a question about cost is because, what I think we're all doing here is we're talking about value. So when we talk about, you can't really have a cost conversation without understanding what the total value of the thing is that you're doing. So again, like, not to beat a dead horse here, but this concept of, we are in a mostly fee-for-service transactional environment where it's like, no, this is what it costs to treat pneumonia. This is what we get paid, plus minus equals, right? In this program, and I'll take it back to sort of all of the different touch points that Sharon mentioned around readmission rates, net promoter scores, connectivity to system, right? Like, this is my healthcare system. They came to my house and took care of me. So when we talk about the value, the net value, that is the thing that I think has to come into these cost conversations in a way that when we're really talking about brick and mortar and sort of fee for service, it doesn't. So I think as people are evaluating, like, what is the cost of doing this? I think this other conversation also has to happen, which is what could be the total value? And that does get us into this conversation of, are you the provider? Are you at downside risk? Are you in value-based arrangements that then make each admission to your hospital at home, a multiplier in terms of the value of that?
Sharon, do you agree value has to be really important even in the discussion around whether we can actually do it financially?
Yeah, I think absolutely. We're seeing that as we compare populations that are acute in brick and mortar versus patients that are in our in-home setting, we are providing less expensive care with better outcomes, right? So we're seeing that value for sure. I do think as hospitals, and we were one of them, we wanted to get pretty quickly. We didn't have a large infrastructure already. And so we ended up, going to a vendor and vendors. I think that might be a good first step, because the other challenge is if you get all this cost on board and try to do it all yourself and you're growing slowly, there's a cost to that, and we can talk a little bit about patient acquisition, which is, I think, has been challenges across the country on how many patients really can fit into this model. So I do think, now we are, up and running, and we're running a regular census, and we're now insourcing that and taking our time to insource, doing a lot of what everybody's talking about is looking at the pros and the cons and the costs and what we want to insource. So I think there's a couple models from a cost perspective, but always have to look at the impact from a quality, contribution margin, those things, as well as maybe, you outsource more in the beginning, and then you decide to insource as you get more stable in a population where, then that cost, because you're going to incur that cost, whether you have patients or not. And I think that's the challenge, is ramping up to the census that you're driving, and not over spending when you don't have that census, and then your per case cost is very high.
So I'm going to go to Tahir next with the conversation, keeping the topic and theme of cost for just one more question. Reimbursement is a big issue too, right? Reimbursement of RPM, of telehealth. When you go and talk to health systems about Bioformis' technology, how often does the reimbursement issue come up, and how do you interact with payers around this?
Yeah, so I think reimbursement for RPM and telehealth is probably a smaller focus of the conversation. You'll know that kind of more recently, prior to the omnibus bill kind of being approved, the reimbursement of hospital at home was just such a big question mark. I think with the rapid growth and adoption of hospitals and health systems implementing these programs, I think the question now turns towards how are private payers going to reimburse for hospital at home. Speaking kind of from the technology perspective, the technology layer is, I would say, an essential component to any care at home program. It helps you scale, it helps you have your staff be more efficient and effective, and adds a layer of kind of safety as well. But compared to the other costs that a hospital at home program incurs, the technology portion, I would say, is actually minimal.
Interesting. Dr. Brown?
Yeah, I think just sort of building on, I agree with what Tahir said. I think and as folks are considering what the sort of complexion of their hospital at home is as it relates to sort of technology and scaling, the challenge is not to use technology to rebuild what happens in the hospital, right? It is about how do we use technology to move forward the things that elude us in the brick and mortar setting. So I think that sort of that foundation of like, how if we were going to build this from scratch, what are the best ways for an interdisciplinary team to communicate? What are the best ways for family members to know about that? What are the best ways for the patient to get educated? And then the technology becomes the enabler of really changing the paradigm of how we deliver care. So I would agree. It is incredibly technology forward, and it is about it really is about pushing your model to not just replicate this thing that happens in the hospital, which we all recognize has challenges, but to really innovate around a new paradigm in care.
Same question to you, Sharon. How much does reimbursement reflect in what you do?
Yeah, so, I always consider like RPM, and hospital care at home really is under a DRG payment from CMS. So you're not billing extra RPM. If the patient then continues in, any type of care after that discharge, then there is RPM, and the patient needs RPM, you can actually bill that. But I always look about RPM, that feels very fee for service to me, transactional. And I go with Dr. Brown in that it's really about the value. And because patients have copays with RPM, and the way it's designed. So I always think about using the technology, and the technology advances are amazing. Like, you can't keep up with them. I think that is a big challenge, is as you set into a technology platform, I can guarantee you within 6 months to a year, that platform is kind of, out of date. So you want to make sure that you're working with a partner that actually keeps up with it. The technology is advancing dramatically. You're talking about patch technology. You don't need, all the things that we have on the inpatient side, that those same patches that monitor a patient's blood pressure and temperature and heart rate can go home with the patient, and so I think that chasing RPM from a billable perspective isn't, something that I think is really that valuable. I think doing it from what the patient needs and from a value-based payment perspective and keeping patients in their home really is where the value of RPM is.
We have a question around cost, so I'm going to get to that before we move on from this discussion. The question is, what would bend the cost curve and make economies of scale for these types of at-home services? And we can start with Tahir.
I go back to Zenobia's point about really thinking about what you're trying to do with your program and the care that you're trying to deliver to the patients. And then you can create, the MVP, or kind of a minimum viable solution or product of what you can deliver in the home, and, kind of price that out accordingly. I think what would help, cost control or economies of scale is, as you grow, thinking about, what Sharon touched on earlier, what have you outsourced that you can now look to insource? How can you grow your, let's say, your existing kind of mobile integrated paramedicine team to, take on more visits or do perhaps nightly coverage? And I think that's really what helps a program scale and grow accordingly.
Dr. Brown.
Yeah, I think my colleague said it perfectly. It's, and I'll bring it back to something Sharon said. And I would say one of my biggest concerns is when we start to talk about hospital at home, and then we're saying, well, what is the cheapest you could do this, and still sort of, if you're doing it through the, the CMS kind of program, or if you're doing it through just sort of a contract with a commercial or other payer, like that, you're just getting back into this transactional model, right? And if, listeners out there are many third parties that are building that, right? They will show up with the team, with the tech, with everything. And it's like, what is the least amount we can do and still sort of make requirements and still bill for a hospital stay? And I think that's a huge mistake. It really is this thing of, how do we realize the total value of this thing we're doing? And if it really is preventing a readmission, if those folks really are less likely to have an infection that is then going to lead to additional cost, obviously those people are much more likely to be discharged from home, right? They're much more likely to have a lower length of stay, all of these great things. So if that is all true, and we're here saying, yes, it is, and there's plenty of data and research coming out of Brigham, coming out of, I'm going to imagine Christiana's publishing this as well, then the cost of the thing cannot be separated from this total value, because that is how this is going to drive more revenue than just a hospitalization, right? And that's the thing. This is what we know, right? That's why hospitals are in trouble, because often you're giving more care than anyone is paying for. So really shifting this to a conversation about like, no, what is this thing worth? And then you say, okay, if this thing is worth this, if we can get to these outcomes, these outcomes that are important to families, important to patients, important to our healthcare system, then this is what this thing is worth, and we're going to invest in that.
Same thing for you, Sharon. What would bend the cost curve? So we
Yeah.
can...
I think, as I said earlier, you want to start slow, but you can't continue to be slow in building your census, because you're actually creating a 24/7 hospital, right? You have a virtual hospital that you have the infrastructure for. So, when we started, our cost per case was extraordinarily high, because it was like we built this infrastructure and we had like one patient, and that patient got really excellent care. But then you have to get to a number that actually, from a scalability perspective, spreads those costs over more patients, and that's where we are today, where we're really starting to see the economics, not just the quality, safety, because you can count all those, like less hospital acquired infections, like by a tremendous amount, less readmissions, and they all have a value, a dollar value, but the dollar value of delivering care in this innovative way, and we find patients love it. Patients are have less disabilities after a hospitalization. They're definitely up and walking around, and back to work sooner, those types of things. When you put that all together, it is really bending the cost curve. It's probably one of the most innovative models that I've ever seen in healthcare, that really is making a huge change. And it's really exciting times and I think this is only going to expand to other levels of care in the home that we traditionally move patients to facility-based care.
Mm-hmm. Sharon, I'm going to stay with you and talk about what you mentioned before, patient acquisition. How do you determine eligibility once a patient is acquired? How long are they in the hospital at home program? Is it perpetuity if they have chronic diseases? How do you decide?
Yeah, so I think patient acquisition has been a challenge. It's a very big cultural change. So we're taking patients directly from the emergency department, or patients that have been in the hospital a day or two and now can probably continue their stay in the home. And so the education around just the providers that are delivering that care about this new type of program has been, a huge challenge for us. Initially we did like 3 months of like education, and that, what happens in hospitals, those residents rotate out, and the residents you taught weren't even now assigned to the ED anymore. And so it's this always chasing your tail. So what we've done is we actually put people on site in those emergency rooms. We actually have somebody who sits up in the bed board, so that we're always top of mind as an option for patients. The other, I think challenge is making sure patients understand this model. And so there are screening criteria. Not everybody can go home based on the type of clinical care they have, or some of the, socioeconomic and other determinants. You have to have a home. That would be the first thing. And it has to be a safe place to deliver that care. So it's been really a challenge of changing the, culture. And now that we've got a lot of people better engaged, now that we're part of the operation in brick and mortar to identify and kind of find the right population for this, census is really growing and ballooning. So it is something that you have to really plan for, and continuously, you just can't forget about it. It really is something that we're constantly, tweaking, and we'll have new residents and people coming in July, and we'll start this all over again. And so I think it's just been fascinating to understand the cultural change that's needed to do this type of program.
Tahir, how do you address patient acquisition?
I smiled earlier because it's funny that it's so similar, even though it's a completely different health system. So to Sharon's point, we do something similar. We tackle the issue from both ends. One, we identify a champion in each department that we work with. So in the emergency room, on the floors, that really helps educate the staff about what the program is and what patients are eligible for this program, and really does their best to drive adoption from their respective department. The second thing that we do is we have dedicated folks on our hospital at home team that essentially use tools within the EMR to screen and identify appropriate patients. So we're able to look through the ED board, but then immediately filter based off of geographic locations, perhaps medications that the patient has received while they're in the ED, vital signs, as well as just, kind of what their admitting diagnosis will be, and narrow that pool. So let's just say if there's 100 patients in your ED, maybe you get 50, that list cuts down to 50, and then you can quickly look through that list for appropriateness and then go and approach that patient.
Dr. Brown, you're nodding.
Yeah, and I mean, we relied heavily on sort of the published data coming out of Brigham and Mount Sinai, and talked to lots of other systems, and really what's been described thus far is exactly right. Just we have someone who's physically in the emergency room, and again, this sort of, again, it's the opportunity to sort of change the paradigm around what is that experience of when someone comes in and they're diagnosed with something that needs an inpatient level of care, and then how are we interfacing? I think it also relates to the cost curve. I mean, I know everyone's very concerned about that part of it. And one of the things that we tried to do in this model is, in addition to having assets that were very specific to the hospital at home, because they are, as everyone's saying, like, that's part of the challenge in healthcare, is that people are rotating, right? It is hard to make something stick. So having a designated asset to identify, to use the technology tools to identify patients, and then really have this meaningful encounter with the family and the patient and the caregivers around what is possible at hospital at home. There was also the opportunity to look at what were the assets in the hospital already existing that we weren't going to build in a silo, right? I think that's one of the challenges of healthcare, is that things are siloed. So we were very intentional in our patient identification, in that decision-making around who should be in the hospital home, who shouldn't, that we are bringing the assets of all of it. Like, the hospital is a partner in the hospital at home. It's not hospital at home sitting over here and hospital sitting here, but the hospital is in charge. Whoever's assigning cases, who is talking to, we have voluntary physicians. Not everybody's employed is seeing a provider who's employed by the system who comes to the ED. So how are we bringing that whole workflow into it? So really, as much as possible, as folks are looking to design these programs, what do you have in your system that can be an asset, not additional cost, right? That you've already got some costs in the hospital. So what's there that can feed this program, so that you're not just taking on net new expense, and also you're achieving this thing of using the subject matter expertise, the actual people who can drive some of these great outcomes. And that's everything from like our tele ICU, right? We had that already. So that becomes an asset in our hospital at home, no net new cost, but now we've brought additional subject matter expertise, additional providers who can kind of weigh in on these different cases. So I think that's another important piece of identification, acquisition of the patient, and then this transition to a decision around hospital at home.
Sharon, I'm going to pick up on something you said about the culture change that's required among physicians and clinicians, and combine it with a question that came from the audience. What is the type of provider that works best in delivering these care services at home? Is it hospital employed physicians, or do you lean into community physicians who then bill for this service?
Yeah, so we have really have employed hospitalists that do this model. And, I probably feel strongly that virtualist medicine, I call it virtualist medicine, is its own, has its own knowledge, skills, abilities. You have to be able to use the technology with the patient. And to me, our virtualists are full-time in this program. So I think it would, now we have, and we use physician consults that are non-employed. So if we need a pulmonary consult or cardiology consult, we will go to non-employed physicians, but that's really an audio video visit that we really handle and set up for them. So I probably feel pretty strongly that your core physicians should be employed, because there is an art and science to virtualist medicine. And I don't know what my other colleagues think about that, but that's the model that we've chosen.
Ty, do you want to address that?
I would echo the same. We have our core group of physicians are hospitalists that work part-time on the floors and then work part-time in the home hospital program. We do have a small segment of physicians that are also kind of primary care outpatient physicians that spend 1 week on service while they're doing hospital at home as well. I find that it's better to have that, familiarity with the health system, with the patient population, that really helps drive kind of patient outcomes.
Dr. Brown?
Yeah, it's interesting. I mean, I think we're all looking at this similarly, but with slightly different lenses. And certainly you are going to see programs nationally that are driven by ACP care, right? So we've heard two very heavy physician models, and then there are models out there where there's no physician anywhere. I'm not going to weigh in on what I think is sort of right or wrong, but to say, similar to Tahir and Sharon, we have physicians who are leading these teams supported by ACPs, nurses, community-based health workers, peers, the whole thing, because you need an interdisciplinary team to really manage folks. I think this concept of that, I want to pick up on what Sharon said, it is a special skill to be able to go into somebody's home where things are, it's free range. Anything can happen. You can walk into anything. And that's everything from the technology working, not working, the family being happy, unhappy, the environment being safe, unsafe. I mean, you do all these screenings ahead of time so that you're relatively assured, but it is a special skill set. So you do want a dedicated team who is very, very good at this. And because we quintuple aim, right? The providers have to feel supported. They have to feel like this work is great. And if they're not supported appropriately, if they don't have the skills, if this is not an interest of theirs, right? If this is not their passion, then I think that's a recipe for disaster.
And we haven't talked about data at all. So let's sort of address that with a question from the audience. How do you guys navigate data entry or integration from the home? Are you working with EMR vendors around remote data entry or evolving data entry requirements into accommodate, at home and remote patient monitoring? Tahir, I'll go with you first.
Sure. So I'll piggyback on what Zenobia said earlier. It's probably a mix across the country. It's whatever is probably most comfortable for your clinician. So I've seen programs that have an RPM solution, and then the nurses or the docs will document in the EMR based off of what the data is gathered in the RPM solution. There are folks who do some level of basic integration with the RPM solution that they have. So kind of flow of vital signs to the EMR, and perhaps flow demographic information from the EMR back to the RPM solution. And then you can go as deep as, taking clinical notes from the RPM solution that your providers may be documenting on, or taking telemetry strips and feeding all of that back to the EMR. So it just depends.
Sharon?
Yeah, so, and I would agree to hear. We have chosen to use our base EHR. All of our patients are coming from our hospital. They've been assessed in the ED, or they've been in the hospital for a couple of days. So we use our base EHR, and we just have a thing that says it's virtual hospital. So it looks like a patient care unit, but it's really a separate hospital. And so we've had to do a lot of, manipulation of the base EHR to do this work, but we've done it. And our pharmacy is supporting us for our hospital care at home. So that was really important from the medication management. I think that's the most complicated thing, is the medication management piece. So we wanted to make sure we're delivering the same standards that we deliver in the hospital. And so we have those same processes. So, but the technology that we use, the biometric technology isn't integrated, but we work around it. Right now, I'm not sure what our long-term technology play will be. So I think there's risk of early on trying to integrate everything. I think some of it is just getting it up and seeing what works and what doesn't work. And then as you make longer term investments, because they would be longer term investments to do a lot of that integration work. So that's what's worked for us.
Dr. Brown, how do you integrate data?
100%. I mean, I think very close to what Sharon said. From a, basic, straightforward, how does this information integrate with the system? You wouldn't know they were in hospital at home other than the unit is like the hospital at home unit of the hospital. So all of the data as it relates to blood pressures and medical notes and all these other kinds of things, that's sitting in the EHR. As it relates to the RPM and those components, as Sharon said, it really is, those are the same way. If, currently in some of our hospitals, if the nurse goes in and takes a blood pressure, she's documenting that, and that's how it's getting into the EHR. We have had to do some integrations. Again, Sharon, we're everything's sort of lining up around the other sort of the pharmacy parts of it, the laboratory pieces of it, because the way that information flows is all based on brick and mortar. So you have to create sort of new ways for that information to transmit to different departments so that so that meds get where they need to be, so that, labs are run the way you want them, et cetera, et cetera. So I think it's sort of cobbling some of that together, but mainly it's sitting on the EHR.
When a clinician physician arrives at the home, they get a picture into a patient that you don't see when they are coming to the clinic. Obviously, social determinants of health is a very, very big issue right now, especially after COVID. So what if some of your hospital at home physicians or clinicians enter a person's home and realize that there is a nutrition issue here or some other social determinant issue that is hampering this person's clinical outcomes or improvement or even mental well-being? Do you have systems within place where they can be referred out to resources that can help with those? Do you collect any social determinants of health data? Sharon, I'll start with you.
Yes, absolutely. I think that this is the most powerful part of hospital care at home. You really don't know from a brick and mortar patient how that patient lives, but when you're in the person's home every day, whether they have food insecurity or their safety issues. And so we bring, to Dr. Brown's point, that's an interdisciplinary team with social services and all the things that we need to make sure that when we leave that home, the patient's better. I mean, we had one patient whose home didn't have enough lighting to even care for the patient. So we went out and bought the person lights because we couldn't care for that patient's wound without that. We measure, I don't know whether you've all heard about the area deprivation index. It was originally, I think, crafted 30 years ago by HRSA. So we monitor our patients, and what it does is it creates a national map of areas, and it tells you how highly deprived those areas are versus not from a scale of 1 to 10. And we monitor admissions based on where they're coming from. So we want to make sure that we're not just taking patients who have, the financial and social means. We want to get to those areas that are highly deprived and make sure that we are, from a health equity perspective, going into those more deprived areas and making sure those patients have access to hospital care at home. And we've been very successful by looking at that data and being very conscious of where patients are coming from and monitoring that over time from a performance improvements perspective.
Tahir, do you want to go next?
Sure, I agree with everything that Sharon has said. Through Hospital at Home, you're able to kind of actively and passively gather data and identify many kind of social determinants of health or barriers that a patient may face. One small example that we have is, patients are oftentimes on like 4, 5, 6 different medications on average, and they might not know how to take all of them at the same time. So we're able to, leave behind something as simple as a pill box and arrange their medications and show them how to take it. To the point of food insecurity, we have a nice service in Boston that's able to deliver meals while the patient is hospitalized. But, to the kind of similar what happens in the inpatient setting, what happens when they're discharged from Hospital at Home? So we've really taken the focus on the transition of care and kind of long-term piece as well. So how can I set this patient up with meal delivery service after they've left our program? Or how can I ensure that they have the relevant follow-up with the specialists they need? And how can we kind of asynchronously check in on them to ensure that happens? So all of that kind of put together, we try our best to address barriers to health that otherwise would have gone unaddressed.
Dr. Brown, we're almost coming to the end of our session, so I'll ask you to briefly address this, and then we'll go to our key takeaways.
This is the most important social determinants. But listen, we serve one of the most diverse populations on earth. And as part of our commitment is that all of our patients who are in the hospital are getting screened for social determinants. Hospital at home is no different from that. Instead of sort of just repeating what Tahir and Sharon said, which is exactly right in terms of the opportunities at hospital at home, I also want to sort of flip that and say the other opportunity, because we know there's systemic racism, we know there's biases, is to flip that on its head, which is here's what I thought I was going to find because you live in the projects, and here's what I actually found, which is tremendous strength, tremendous family support. So it becomes an opportunity not just to find the weaknesses, but really to double down on the strengths of people that we miss when they're in the hospital. We are seeing them alone and at their worst. And when we see them in the setting of in the context of their families, then we're able to, yes, see the determinants that are hurting them, but also those determinants that are going to help them to wellness.
Perfect. So I'm going to go around asking for one sentence takeaways. For me, it was value, focus on value, not so much cost when you think about hospital at home programs. So Dr. Brown, I'll start with you. Quick takeaway.
Really quick takeaway, I would say anyone who is in this space, looking to be in this space, it is about redesigning care toward something that is better. And if you use that as your guiding principle and say, what do we want to do here? And I would challenge us as a healthcare system to take that seriously and use this opportunity to move healthcare from a transaction to really a relationship.
Sharon.
Yeah, I think along with Dr. Brown, it really is about approaching it from a quality and safety perspective. You know, there's not a playbook for this, and with that mindset, making sure that you invest the resources necessary to bring that level of care into a patient's home, and it will be just transformational and magical for your health system.
Tahir, I'll let you have the last word.
Sure. So over the next decade, hospital at home will definitely be a mainstream kind of care delivery option for patients. So if you're a health system considering hospital at home, there will be growing pains to overcome, just like with anything new, but it is worth it clinically and financially. If you are a clinician, please consider practicing in a care at home model if appropriate for your specialty. It will be one of the most rewarding things that you will do in your career. And if you are a patient and unfortunately happen to be hospitalized in the future, please ask your team that's taking care of you if you have a hospital at home program. And if you would be eligible for it, I guarantee that you will love it.
Thank you to all of you for this very enlightening discussion, and thank you to everyone who attended today.